Okay, now we're going to talk about one of the most common chronic illnesses of childhood, asthma. We'll talk about what symptoms you can expect to see and cover the basic tenets of inpatient and outpatient management. So, the exact cause of asthma is unknown, but research suggests that there's a number of different factors that contribute to development of asthma and the rate of exacerbation in kids. And the things that we're talking about are genetic factors, environmental factors like air pollution, and even environmental factors that kids can be exposed to in utero, such as tobacco smoke. Now, asthma really isn't a singular disease process, but is really made up of a complex interplay of different symptoms that can present with different clinical phenotypes. So you can have acute symptoms, chronic symptoms, or the more classic asthma picture would be acute on chronic symptoms. But regardless, this really is a process of the small airways of the lungs. And basically, you're having an over-exaggerated response to some sort of trigger. So in most patients, that's either a viral trigger, particularly rhinovirus, or an environmental trigger such as pollution or tobacco exposure. And this is leading to an exaggerated bronchoconstriction of the small airway smooth muscle. You also have an increase in inflammation at this time and edema that leads to further mucus production and air trapping. And this all leads to the classic symptoms that we see, including wheezing, cough, and shortness of breath. And in terms of diagnosis, for younger children, it's really going to be a clinical diagnosis. So you're seeing if when they're having those symptoms of wheezing, cough, shortness of breath, etc., if that's relieved at all by the use of a bronchodilator such as albuterol, or if there's a strong family history of the atopic triad, including asthma, eczema, and allergies. And then for older kids, so for kids older than 6 years of age, really the gold standard are PFTs or pulmonary function testing, and this looks at the volume and speed of exhalation and is typically repeated every 1 to 2 years. And in terms of classifying a patient's asthma, once you have those PFT results, or in a younger child have made a clinical diagnosis of asthma, you can further characterize symptoms into 4 categories. So you can have intermittent, mild, moderate, or severe disease. And these classifications are all based on a variety of characteristics of a patient's asthma, including symptom frequency, so how many times per week a patient has symptoms, nighttime awakenings resulting from those symptoms, how those symptoms have interfered with just daily activities, SABA use or short-acting bronchodilator use such as albuterol, and the FEV or forced expiratory volume, which is measured by PFTs. So to simplify things, a patient will have intermittent asthma if they have symptoms less than 2 days per week, mild asthma if they have symptoms more than 2 times per week, moderate if they have daily symptoms, and then severe if they're really having symptoms throughout the day. Okay, and in terms of treatment, the guidelines really break it down into 6 steps you can take for escalating symptoms. So for patients in that intermediate category, so if you're really having symptoms less than a couple days per week, these patients are typically managed by short-acting beta agonist alone, like albuterol, for as-needed symptoms. This is an inhaled medication, so the use of a spacer is imperative. Patients will typically take 4 to 8 puffs as needed. If you're having symptoms more than a couple days per week, then patients are typically started on a low dose of an inhaled corticosteroid, such as fluticasone or Flovent, with the starting dose being 44. And again, this is an inhaled medication, so use of a spacer is very important. If you're moving to more daily symptoms, then we really want to maximize the dosing of that inhaled corticosteroid, which typically is bumped to 110, 2 puffs twice a day. Again, if you're having even more frequent symptoms, then patients are typically started on a long-acting beta agonist, such as salmeterol or Advair, which again is an inhaled medication. The next step would be to further increase corticosteroids or possibly add a leukotriene antagonist, such as Singulair or Montelukast, especially if patients are having more common triggers from allergic symptoms. And then for the most severe cases, you're going to talk about oral steroids as well as possibly adding a MAB biologic drug. And then I just want to briefly mention something called the Asthma Action Plan, which is actually a really integral step to appropriate management of these asthma patients. Because as you can imagine, patients might have a variety of medications and they just aren't sure of when to use them. And the data really suggests that when patients have a clear plan, it leads to better management of their asthma, and then they present to medical attention at a more appropriate time. So basically, an asthma action plan is kind of laid out like a stop sign. So you have green medications, yellow, and then red. So let's use this little girl as an example. So she has mild asthma with symptoms maybe 3 times a week. So every day she's going to be taking her Flovent, so that's why it's a green medication. If she has those symptoms of cough, wheezing, shortness of breath, etc., she should take her short-acting beta agonist or albuterol with a spacer device. And again, that would be 4 puffs every 4 hours as needed. But let's say she can't get to 4 hours and she starts having those symptoms again. Well, that would put her in this red category where she should still continue to get the beta agonist, but she should also call her pediatrician, or if parents are more acutely concerned, present to the emergency room for further evaluation. Okay, and let's say a patient is in that red category. So they're having these symptoms that either aren't relieved by the use of their albuterol at home, or they can't go 4 hours without a treatment. So let's say that child that we showed before with mild asthma presents to her PCP, and the PCP hears wheezing diffusely, but feels like she could probably get to 4 hours, and then having to repeat that albuterol treatment. So that patient's probably safe to be managed at home, but they would need oral steroids because that's the important second piece of treating an asthma exacerbation, right? Because the albuterol is just working as a short measure to combat that exaggeration of bronchoconstriction in the small airways. But really, steroids are what's needed to combat that overall level of inflammation. And there's no real general consensus about the amount of steroids. Suggested amounts really range from 1 to 2 milligrams per day. That can be given daily, once, or it could be divided twice. And again, the duration kind of varies. So you could give a couple days of treatment. Sometimes, typically, outpatient providers will typically give a 5 to 7 day course. But let's say the provider is more worried and they feel like this patient just can't get to 4 hours without a treatment. So those are the asthma patients that are typically referred to the emergency room. Once getting there, they might be given a stacked nebulizer treatment, which is something we talk about, which really you could give a patient 3 breathing treatments at once, and sometimes that helps just open up those airways. Often the short-acting beta agonist can be combined with something like tiotropium into a duo neb, and that's been shown to further lead to opening of those airways. Steroids should be started as soon as possible, just like I had previously talked about, to combat that level of inflammation. And then in terms of patients that need to stay overnight in the hospital, that's really coming down to the fact that they're just not able to go 4 hours without a breathing treatment. And here at UVM, patients that can go up to 2 hours without a treatment are appropriate to be managed on the floors with respiratory therapists closely watching them. But if albuterol is needed more frequently than that, so what we call continuous albuterol or treatments needed every hour, those patients are really more appropriate for the ICU. And other medicines that you might use at that point would include magnesium and terbutaline, which are really reserved for more severe acute asthma exacerbations. And just to clarify for oral steroid dosing, so you're really talking about 1 to 2 milligrams per kilogram per day, and that really maxes out at 60 milligrams per day total. And in terms of going home for these patients, things that they have to be able to do, obviously they have to be on room air and not need any additional oxygen. They have to be able to get to 4 hours without needing a breathing treatment. And then, of course, you just have to not be overly concerned about their work of breathing, that they're going to need further respiratory support. And that's it. So certainly not an exhaustive look at asthma, but just a nice overview of the clinical things you need to look for and basic tenets of inpatient and outpatient treatment. Nice work.